Because the subject is very important, in 2012, the American Nephrology Nurse Association created a collaborative special project group called the Venous Needle Dislodgement Special Project Work Group. The job was to review the venous needle dislodgement and consequences and recommended practice to avoid this complication, and to develop strategies and resources on venous needle dislodgement to be used by the nephrology nurses and other healthcare professionals. Actually, this is very important, although it's very simple, but it's very important how to fix the needle for dialysis. The needle is fixed in place by this rectangular adhesive fabric. Then, a very important step, which is the second step, the tape used to make the chevron in position under the needle tube close to the adhesive fabric. So we have this part with the sticky side upward. Then this is flipped up to have this end shape. This is very important to avoid needle dislodgement, and this is the ideal way to fix the dialysis needle. We have to follow these steps to avoid needle dislodgement. Awareness. We have to educate, we should have education materials for the staff, patients, and the care providers. The area around the vascular access should be cleaned and dry before cannulation. The blood line should be lubed loosely to avoid traction on the needles causing dislodgement. And it's very necessary, if we need to reposition the needle, that we should use a new adhesive plasters, not use the old ones. And the vascular access and needle should be visible all the time during the dialysis session. This is very, very important. This is very important to keep the needles and the vascular access line exposed to detect early bleeding and to save the life of the patient. This is example for the catastrophic hemorrhage from infected fistula that necessitates tourniquet applications, and this is example for fatal retroperitoneal hematoma complicating femoral caster insertion. Now we'll move to the second catastrophe, air embolism. Although it's rare, but it's fatal, causing chest pain and dyspnea during hemodialysis. We can suspect it when we found foam in the venous blood line. This is an indicator for suspicion of air in the system, and disconnection of connecting caps and or blood lines can also lead to air embolism in patient being dialyzed with central venous catheters. The symptoms of air embolism depends on the position of the patient during dialysis. If the patient in the seated position, air tends to migrate to the cerebral venous system without entering the heart, leading to loss of consciousness and maybe fits. If the patient developed air embolism in the recumbent position, air tends to enter the heart and then the lungs, causing dyspnea, cough, and chest tightness. How to treat such catastrophe? Number one, clamping the venous line and stopping the blood pump. Then, positioning of the patient on the left side in the Trendelenburg position with his head tilted downwards. Cardiorespiratory support should be available. and administration of 100% oxygen by either mask or even intratracheal tube. And the most important aspect of air embolism is prevention by adequate function of the monitoring devices and alarms in the dialysis machine. These are some examples for the causes of pulmonary embolism, which could be caused by lacerations either in the serge, like in this case, this is the heparin serge with the lacerations, and this is the ciliatic tube which was used earlier in the dialysis through using the shunts. This is not used nowadays, but this were source for air embolism. And this is, as I said, the air embolism when the patient developed in the seated position. We can see that this is the upside, this is the air bubble here, and here in the cavernous side. So this patient is vulnerable to fits and loss of consciousness, which could be fatal. And this is a typical dramatic scenario for the patient who developed pulmonary embolism. Shortly after starting the hemodialysis, the patient began receiving hemodialysis treatment. His venous bloodline separated from the catheter. Shortly, the venous bloodline was clamped. The patient complained of shortness of breath, then increase in the respiratory rate, immediately placed on the left side, Trendelenburg position with 1 liter of oxygen per minute, and in spite of that, I transferred the patient immediately to the ICU. In spite of that, the patient dies. So this is the typical scenario for fatal pulmonary or air embolism. The third catastrophe is developing of hemolysis. Again, it's unusual, but it is potentially fatal. Causes of hemolysis may be hemolysis will be causing, the result of destruction of the RBCs by overheating of dialysate, using hypotonic dialysate, kinks in the blood tubes, malfunctioning of the pumps, maybe contamination of the dialyzers by formaldehyde or chloramine, nitrate or copper from the water supply. All these will cause oxidation and reduction for the RBCs, leading to their destruction and hemolysis. This is a case report about the chloramine-related hemolytic anemia in home, which was used for disinfection of the dialyzer in case of reuse, which is not, I think, used nowadays in Rex. Again, the kinked lines can cause hemolytic reactions, and this hemolysis could be a cause of fatal pancreatitis. How to suspect hemolysis? Chest pain, tiredness, abdominal and back pain, headache, nausea and malaise. All these are non-specific symptoms, but it should be considered if several patients in the unit complain from similar symptoms simultaneously. And venous blood became more darker, and the plasma, which is supposed to be clear, become pink, and there is dropping hemoglobin, and the most important that with this hemolysis there is life-threatening hyperkalemia, which could not be recognized and could be fatal. Treatment: we should stop dialysis immediately, clamp the blood lines, and very importantly, don't return the blood to avoid hyperkalemia. We should manage hyperkalemia urgently and try to investigate the cause of hemolysis and hospitalization or observe the patient, since life-threatening hyperkalemia may develop after dialysis has been terminated. The fourth catastrophe is fatal anaphylaxis. Anaphylaxis may be occur due to the use of ethylene oxide sterilized membranes or complement activating cellulose, polyacryl nitride membranes, or high flux membrane, or to certain drugs like ACE, heparin, and iron. Whatever the cause, if it's IgE dependent or independent, this will cause muscle destabilization with rupture and release of a lot of cytokines, causing the symptoms of anaphylaxis. Anaphylactoid and acute hypersensitivity reactions generally occurs during the first 30 minutes or maybe in the first 10 minutes of hemodialysis. And in cases of ethylene oxide allergy, it may start later and even after the end of the session. These are the manifestations of acute hemodialysis membrane-associated reactions. There is skin pruritus, erythema urticaria, mucosa of the inflammation of the eye, mouth, and respiratory tract, causing even angioneurotic edema, dizziness, syncope, alteration of consciousness, bronchospasm, etc. What is the management of fatal anaphylaxis? Acute management and then identification of the offending materials and try to treat it. Acute management, stop the dialysis session, again without returning the blood to the patient and cessation of eventual drug supply. So in cases of hemolysis and anaphylaxis, don't return the blood to the patient again. Adequate, general and specific individualized procedures, and epinephrine should be administered to patients suffering from hypotension, shock, airway angioedema, or definite breathing difficulty. Antihistaminics, corticosteroids, beta-2 agonists in case of bronchospasm. Airway, breathing, circulation, level of consciousness should be assessed carefully. Then we try to identify the offending material by careful history taking of the patient and from the physician as well. And thorough revision of the medical reports are mandatory for proper diagnosis. We may use diagnostic methods like quantification of specific IgE or basophil activation, etc. However, these investigations should be postponed until 4 to 8 weeks after anaphylaxis episodes, because these cytokines may influence the test by medication used to treat the anaphylaxis. The last catastrophe is cardiac arrest and sudden death. Causes are extreme hypotension, electrolyte imbalance, especially hyperkalemia, development of arrhythmia, myocardial infarction, embolism, and severe blood loss. If the arrest occurs immediately upon initiation of the dialysis, the cause is unknown, blood should not again be returned to the patient. The dialyzer should be checked. An anaphylactic reaction to the dialyzer membrane or infusion of formaldehyde from inadequately rinsed reused dialyzers could present as cardiorespiratory arrest during the initial period of the session. If cardiac arrest occurs during the dialysis session and there is no reason to suspect problem with dialysate composition, blood should be returned to the patient promptly. A sample of dialysate should be sent for immediate electrolyte analysis along with the patient blood samples. the dialyzer and bloodline should be saved for later analysis to detect the cause. This assessment is performed simultaneously with removal of the patient from the dialysis chair and placed on the floor to start the cardiopulmonary resuscitation. Access line should be remained in place to provide a route for administration of saline and medication. Don't remove the dialysis needles. After any cardiopulmonary arrest, the dialysate machine should be replaced until its safety features have been thoroughly evaluated for possible malfunction. This is a big study actually on more than 5.5 million of patients over 9-month period. 400 cases reported to develop cardiac arrest. Cardiac arrest was more frequent during the Monday dialysis sessions, the longer period between the two sessions, than in other days. It was more frequent in older and diabetic and more likely to use a catheter for vascular access. And treatment was cardiopulmonary resuscitation and defibrillation. What are the predictor and outcome of cardiopulmonary resuscitation? The predictive variables for cardiopulmonary resuscitation in hemodialysis patients were more among females, patients who had ischemic heart disease or heart failure. So please don't forget the presence of defibrillator in the dialysis unit. What is the take-home message from this presentation? All resuscitation facilities should be provided in the dialysis units. Cardiac monitoring device with defibrillator, a ambu bag, suction apparatus, functioning laryngoscope, endotracheal tube, oxygen supply, and drug commonly used in medical emergency. And we should have planned preventive maintenance. All machines should have a planned preventive maintenance and technical safety, which should be checked periodically according to manufacturer recommendations. And all these should be documented. Monitoring of the patient during dialysis, the dialysis treatment should be monitored closely with particular attention to any intra-dialytic complications, the vital signs, and don't forget to check the dialysis access with the vital signs and report it periodically during the dialysis session. Vascular access monitoring during dialysis should be monitored for if we dialyze the patient through fistula, for the blood flow, the venous pressure, thrombosis, infections, presence of ulcers, erosions, etc. And for the catheter, for exit site inspection for catheter thrombosis, symptoms and signs of catheter-related bloodstream infections. And we should have this type of culture, a culture of safety. The concept of a culture of safety has to be cultivated. This is very important. First, our goal is prevention. We cannot wait for one of these catastrophes to occur. Second, safety extends to outside the dialysis facility. And we are responsible for preventable events in our patients, not only when they are in the facility, but all times. And this is our hope and our aim to have safe dialysis. Thank you.
Thank you, Professor Ayman, for this very informative and clear message, very informative lecture and clear message.